better idea family medicine, how family medicine works here in Canada. Usually what happens is basically we get a family physician for ourselves and we go to him, and then he refer us to some specialist. So we don't directly go to some specialist. What happened here in Canada is basically we go to our family physician, and if our family physician feels that we need to see a specialist, then we will be recommended to some specialist. Okay, so our first approach is, as a patient, is towards a doctor who is basically family physician, or in a walk-in clinic, or in a emergency approach. So our first approach is basically there. And even in when you are going to an emergency physician, what he does is he treat your emergency and refer you to go to your family physician for further counseling, or further what you need to change in your diet, or what you need to do in your behavior, or any medication you need to start, or any follow up. Everything is done by family physician. So that's why family medicine is very important here in Canada, especially. That's why I said you need to at least remember two approaches. Which one? First is emergency, and the other one is clinic. They always mention in the scenario that a patient is coming to the clinic, a patient is coming to you for the first time. So when a patient is coming to you for the first time, where is he coming? Not in emergency, he is coming to you in a clinic. Now you are working either as a family physician. A lot of ethic questions come. As a family physician, you are working and this patient came to you, what are you going to do, right? So it is important as a family physician either for to deal up with the ethics question, to deal up the basic questions, to deal up with the specialist. So your approach should be very vast in the family medicine, and you need to know your limit. It is very important. You are not going to be everything, because in our countries we do everything, but in family medicine we need to know where we are going to stop, and now we need to refer to the specialist. Now starting from the first, everything is like what I told you is written here in the college aspects of the family physician of Canada. So everything is very nicely written here. If you can give it a read, it would be nice. If not, then what I told you is more than enough for you. So privacy, everything, like, you need to know in the family physician aspect, basically how you are going to deal with the ethics, and at the same time a physician patient relationship, how are you going to start that relationship, and how you are going to take it from there on, how much patients come to you. If you ever work with any clinician or any physician who is working in a clinic, or family physician as an assistant, you get to know that how he is working. So it will get you a little better idea. Then coming to the periodic health. So family physician doesn't work as a treatment, sorry, he doesn't give only treatment, but also his main approach is prevention as well. As in today's topic in pediatric, I mentioned not just the treatment is important when you are mentioning the management, but also prevention is important. Sometimes what you do is your approach is prevention first, then comes the treatment. But in some things, you need to write down the treatment first and then the prevention. But prevention is part of some specific treatments, like how you are going to treat the STIs. What are you going to do? You are going to give that treatment, but at the same time, you are going to counsel that you don't do sex meanwhile while you are having treatment. Use the condom method, or use the barrier method, or anything like that. This is what this is prevention. So you are going to treat the partner along with it. So just giving the treatment is not enough. When they are giving you 2 or 3 lines, believe me, those 3 or 2 lines are not just for the treatment. Those 2 or 3 lines are also for the prevention, or they want you to write what you at the point feels like important. So if you know what is important, you need to write along with it. So allow prompt treatment and prevention. So you need to know there are 4 types of prevention. Only 2 are written here: primary, secondary, and tertiary, and quaternary. So and even a primordial ones. Now this fourth one added in this like last year. I'm not sure before it was there or not, but this is added as well. So make sure you know about that. Primordial is basically when you are asking the patient, when there is nothing happening, you asking the patient to wash your hands just before eating. That is basically you are letting the patient know just even before any disease is about to happen, right? That is basically primordial. Now coming to the primary is basically giving vaccination, immunization, everything that is basically you are going to give or inject into the body. That's basically vaccination, immunization, talking about those stuff. This is basically primary. Or putting a prevention in a place where there is a disease going on. So this is basically primary. There was one question that I saw in one Q bank, that a patient, a village is having what a village is having some people who is doing suicide. So you are putting a telephone booth or that place to prevent the prevention. So that is basically primary prevention, because at that particular place suicide is happening and you are putting a telephone booth over there to prevent that. So basically that is called primary prevention. So they were asking which prevention is this. So you need to know, your understanding about this prevention is very important, just not on the basis of vaccination or treatment. Your idea of that prevention should be very clear. So if they ask you in any way, you need to know, yeah, this is primary, this is secondary, this is tertiary. Okay. Then coming to the secondary, secondary is basically when you are going to for the screening, like having some people with the family history of breast cancer, having family history of the lung cancer. So you are going to start the screening at that particular point to prevent the prevention, to prevent the disease to happen before the time. Then coming the tertiary, when the disease is already happened, now you have to prevent it the further, like having diabetes. What are you going to do? Nephropathy, retinopathy, to prevent the further complications. Then in quaternary, quaternary, what is that? Basically, already a disease happened. You already treated it. Now you are going to prevent, like having amputation. After amputation, you are going to put the leg, or putting that amputated the prosthesis or something like that. So this is basically prevention, or helping the patient from developing further, or having the psychological trauma and preventing that. So those are all. So you need to know a proper better idea, at least know primordial, primary, secondary, and tertiary. The last one is not that important, but it is added, so just get a little bit idea about that. Then coming to the next one, classification of the recommendation, you can read it. It's basically written that strong and conditional, which one is strong and which one is conditional. So basically strong is basically when you do colonoscopy for every individual who is coming to you, without any, regardless of anything. This is basically doing out without any undesirable effect. Then conditional is basically like having pack of 30 pack history smoking, then having those particular conditions should be filled, then you are going to do the screening. So that is basically the strong and conditional one. Having abdominal aortic aneurysm, you have to do in particularly females after male in after 65 years, but in female you need to know those particular conditions which she should be fill in. Then you are going to do the screening for the abdominal aortic aneurysm. So those are called conditional, like having certain conditions. Now you are going to do strong is basically you have to apply for the all of them. Then quality of life, at least know these ones, general and special ones. What are you going to do in those particular people who are coming to you? The discussion is basically giving them counseling with your mouth. Like telling with your mouth means you are going to tell them to do everything, like dental hygiene, poverty, smoking cessation, talking about good food, good height, alcohol. So you are going to talk about all of this. This is basically general approach, how you are going to counsel. If they ask you to write it down, if you know any of these, wherever it fits, just put it over there. Like having physical activity, like in those people who are coming with obesity, you are going to write on the physical obesity activity over there. For smoking, when people having hypertension, where you are going to write for the dietary having hypertension, right? So if you know a general approach, you are going to put these particular words same over there, where they're asking how you are going to what are you going to tell the patient when you are discharging that particular patient. So sometimes they ask you about the post counseling when you already did the treatment. Now they don't want you to write on the treatment. Now they want you to, what are you going to tell that particular patient who is going home, right? So if you know this discussion, you can easily write these words over there. So this is basically special population. So this is for the general one. Now this coming is basically pediatric, adolescent, perimenopausal. So all those specific conditional people, what you are going to tell those particular people, like having this home visits for the high risk family, like how when you report to the CAS and you feel like this child is neglect, so you are telling the CAS is going to do home visit to see if that family is actually doing that child neglect or not. Then injury prevention, this is not something you are going to tell to the adolescent, right? So this is the particular condition for, or these are the particular counseling for the pediatrician. Then coming to adolescent, so you are going to do is the sexual activity, contraceptive. If a female coming to you for the first time at 14-year age, now what are you going to do? This is the only question they will give you. 14-year-old female came to you for the first time, what are you going to do? So you have to talk about sexual history, contraceptives, talk about smoking, substance, depression. These are the things you have to talk to the adolescent. If you know this one, if a one line question came to you, you can easily write this one. But if you don't know this one, what are you going to write? You will be confused, right? Then coming to perimenopausal, you have to assess for the risk of osteoporosis, having fractures. So main thing would be osteoporosis. So you have to counsel about that. Then to the adults, you are going to see fall, urine, it is a very good abbreviation, like gait, urine, then comes drugs, GUD, and there was one more word. So it is very nice, like gait, urine, drug, and then vision and hearing. Yes, these five things you cannot miss in adults, even in NAC, OSCE, even in QE1. So if they ask you to ask five things or counsel about five things, these will be the five things. Okay. Then physical, this is not written here, so make sure you write it down somewhere, so it will be very easy when you are doing next time. What are the five things you cannot miss in adult? Okay. Then coming the physical examination, blood pressure you are going to do. This is basically physical examination. This was all what are you going to do with orally, right? That's why I said with the mouth. Now you are going to do with the hands. Okay. It's very easy to remember. What are you going to do with the mouth is like having counseling session or telling them what you are going to do. Then with the hands, what are you going to do? All those non-invasive things, not invasive. Now we are not even talking about any invasive procedure here. We are talking about the general approach. If a family physician, if a patient is going to the family physician, the first thing you are going to do is history, physical examination, then moving on to the investigation. So this is how the approach is. Discussion is history, physical examination is doing BP, weight, if somebody is coming to the for the first time. So we need to take all the like hidden history, all the exact how the patient is presenting, like weight, height, BMI, how he was before, now he gain any weight. So these are all the basic approach, right? Then coming to the pediatrician, pediatrics, if this is what we have done, but in pediatric, these are even more things that you need to add. Then coming to the adults, what are you going to do after 65? Hearing, vision, as I already told you, you cannot miss hearing, vision, gait, urine, and I don't know, I forgot. Okay, first degree relative with a melanoma, full body skin exam. So if somebody has a family history of melanoma, so you have to do full examination, maybe having a one black mole, he was suspecting as a black mole, but might be it's a melanoma. So make sure you take the picture, see it from Google, how does melanoma look like. Then folic acid supplementation for the pregnancy. This is basically a prevention approach, right? How you going to counsel, and you need to know where you are going to increase the dose for the folic acid. Having a history of seizures, having a history of neural tube defect, having a history of any family history, having this is a high risk patient who are high risk patient. And in this one, you are going to increase the folic acid dose at least 3 months prior and after to the 12 month. Usually what do we do is basically 0.4 to 0.1, at least 2 to 3 months. But in these particular conditions, you need to remember which one are those conditions there where you are going to add 5 mg of the folic acid. Then coming to the 12 month of the post conception, because he is breastfeeding, so he needs folic acid as well. So you are going to add these things. Women with the additional lifestyle, with the having medication, birth control, teratogenicity, so higher folic acid should be used. So these are the conditions you need to remember where you are going to use the folic acid even in higher doses. So if you are writing just folic acid, it's not gonna give you like a mark. So you have to write on high dose of folic acid if they are particularly mentioning these conditions. Okay. So you need to know what you are writing when you are writing CDM. Just writing those specific words are not going to give you. You write down folic acid, you came home, you were like, oh yeah, I write down right. But particularly writing high dose are going to give you an answer. Just writing folic acid is not a correct answer. Okay. Then test. What test are you going to do? This is now coming to the invasive investigations, like doing CT scan, MRI, where you are going to do screening. So all of these things. Then therapy. What are the therapy you're going to give? Folic acid, pharmacologically, and these all tetanus vaccination. So you are going to talk about the along with the treatment with prevention. Prevention is basically all this vaccination. So I told you the therapy doesn't include in the family practice. Prevention comes first, then comes the treatment. Even when you are going to start with the NAC OSCE, you will see when you are doing post encounter questions, the post encounter question, whoever you are taking courses or whatsoever you do, they will tell you first comes non-invasive treatment. That is basically counseling, telling about what their lifestyle should be, and now moving on to which treatment or drugs they need to add. So your approach is very different here in Canada as a family physician. Okay. Then coming to the special population, so you are going to add what kind of the test needed to that particular patient, like having ST high risk group. It is very nicely written in gynae. Who are those high risk group, like having less than 25-year age and she is already sexually active, having multiple partners, not using barrier methods. So all of those are high risk patients. So what are you going to do? It's HIV. And HIV is not going to, you are not going to write down HIV, I'm going to do HIV. Like I saw one of the messages in the group and they were saying doing HIV. No, you cannot do HIV, HCV, hepatitis Even such STIs, you cannot screen without particularly asking about the patient consent. You have to ask, I will offer HIV, I will offer this, I will offer, because you are not going to impose your thoughts into that particular patient until that particular patient doesn't want it. This is very, very, very important. Don't think in the patient benefit. Think what patient wants. Autonomy comes first, then comes beneficence. Make sure you remember this thing. Whenever you are writing treatment, wherever you are writing treatment, you need to know which type of words I'm using. Okay. Then pediatrics, TB, and syphilis. Even in TB patient, if she now this is different. Doing STIs, because this is not going to spread with the like with the air, right? But TB can spread with the air. If somebody is coming, this is like an ethic question, so I just wanna put a little like effort here so you can remember it. If somebody is coming with a TB and they don't want to get the treatment, what are you going to do? You are going to report to public health. Okay, because this is TB, this could spread from one person to another with air particles. So you are going to put the patient into isolation. Along with it, you are going to do the treatment. But in STIs, it's not going to spread with the air population, but at the same time it could spread to the further population. If you are suspecting STIs, you are going to confirm it with their consent, and then you are going to report to the public health. Okay, so you need to know a little bit here and there a difference which is happening here. So then comes the therapy. Obviously the therapy comes with a different how you're going to do TB, HPV, influenza, and those things. Okay, then this is the immunization history, how you're going to do the immunization in these particular people, like pneumococcal, more than 65, add Prevnar, and these things. Okay, then comes the vaccine screening. So I want to tell you that in screening you need to remember at least three or four things at least. What is the first thing? The age factor, at which age you are going to do. I mean, remembering all of this is good enough, you can do it. But what you need to remember, age, at which age you are going to do. If that particular person is capable of getting the breast cancer, like or sorry, breast cancer screening or lung cancer screening or colonoscopy, or if should be done or not. Okay, which test you are going to do, how often you need to do. You can write it down. It will be very easy for you if you can write it down. What test, what age factor, how often, and if that particular patient is fitting in the criteria for some screening, not all of them. Okay, now starting with the age. What is the age? Age is 50 to 74. What test you are going to do is mammography. How often you are going to do? 2 to 3 years. The decision of undergoing is conditional on the relative value that the woman places on the possible benefits. So you are going to start with this, then mammography, and then 2 to 3 years. So you are going to start at 50 to 75. It says 40 to 49 recommend not screening. So this is the thing you need to remember. Okay. So this is how it is. Then rest of the things, it says you don't have to do clinical examination, you don't have to do ultrasound, MRI, those things are not done. So particularly you need to remember what test, what age, and how often. Okay, at least these three things. And then in some particular things you need to remember where the criteria fit. Now coming to that conditional one, lung cancer, it is not applied to every single person you are going to do lung cancer. Lung cancer should be done in particular patient which fit in this particular criteria. Okay, now we are going to talk about that particular criteria. What is the age? 55 to 74. How much pack you need? More than 30 pack per year. They will give you particularly at how many pack they use at particularly per day. So you are going to do the little multiplication, then you find out if it's more than 30 pack or not. Okay, if they say they are using 2 sticks per day for last couple of years or last 3 years or something like that, so you have to multiply according to that and you will see if it's more than 30 pack or not. Then if that fits in the criteria of more than 30 pack, then the age is like that. Or even he has who are currently smoking for this much pack, or who has quit in last 15 years. If the patient is coming to you who is let's suppose 75, not 75, 65-year-old, he's smoked 2 pack and he has been smoking from the last 3 years, uh, or you can say he quit 13 years ago. Now you are going to do is 2 pack multiply by 7, which was like the whole week, or you can directly multiply with the like whole 3 years how many days, blah blah blah, all those multiplication you can do, and then you can find out how much pack history it is, and then on the basis of that you are going to do the lung cancer screening, yes or no. But at the same time, if he should be fitting in these two criteria, either he should be doing the 30 pack smoking history, currently smoking, or at least quit in less than 15 years. I have seen couple of questions where the investigation was no screening for the lung cancer. So don't hesitate if you find out that this is not fitting in this criteria and no cancer screening. So don't hesitate to write down no screening. Okay, it is totally okay. Maybe some patient doesn't fit in that criteria, so writing down no investigation is totally fine and okay. Okay, then how often you are going to do annual screening, which test you are going to do, low dose CT scan, up to how many times, 3 consecutive times. So it was very nicely written here. So you are not going to do 55 to 74, you are going to do concurrently every year up till like 74 years. It could be more than that. So you have to do only 3 times. If those 3 times comes out negative, any of the test comes out positive, you are going to keep on continuing it. Okay, so 3 consecutive times means 1 2 3, the continuous time was test negative. Okay, so this is how it is. The words are very important. This consecutive words is very important. 3 tests are not important. Having 3 consecutive tests are important. Okay, so make sure you remember these 3 consecutive words. How you are going to put this 30 pack history smoking, it should be quit in less than 15 years, it should be currently smoking, or 55 to 27 74 years. So this is important. Okay, for all those adults regardless of the age, smoking history, or other risk factors, you should not be doing screening. So this is what I was talking about. If the smoking history or other factors does not recommend screening, like having those history of less than 26 pack, or they were coming with less than like 28 pack, you are not going to do. It should be more than 30 pack smoking history. Okay, so it is important. Then moving on to the next, colorectal carcinoma, the age, as I told you, you need to remember which test you are going to do. FOBT. FOBT, how often you are going to do? Every 2 years. If you are going to do flexible sigmoidoscopy, how often? Every 10 years. So this is what it is. Okay, this is going to be done in every population. Now coming on to the specific population, those specific population are who have the family history. Not every person has family history, only particular people have family history. So 3 things you need to remember: age, which test, how often. Then coming to the special criteria, which is basically fit in those particular people, like having lung cancer, having abdominal aortic aneurysm, having colorectal cancer. So their screening would be little different from the usual one. Then what is this? A man and woman, if they are symptomatic, what are you going to do is diagnostic workup. Then asymptomatic regardless of the age, but positive family history. You are going to do HNPC, like having this HNPCC history and FAB. Obviously, this is hereditary non-polyposis colorectal carcinoma. So this is basically hereditary. So you are going to do is genetic. Familial adenomatous polyposis. This is familial, right? So this is basically coming from the family. So you are going to do is genetic counseling. Genetic counseling means telling about the patient about their next pregnancy. Genetic counseling is telling them about their next pregnancy, how often the chances of having the next particular child, how much percentage they will have this disease. Okay, then HNPCC, if it's diagnosed, what are you going to do is basically colonoscopy every 1 to 2 years, begin at the age of 20 or 10 years younger. So anything that comes first. If this patient is coming at 18, you are going to start it right away. If that patient is coming at 10 years younger than the particular patient who had already history in the family, and that is coming right now, so you are going to start it right away. Then familial adenomatous polyposis, what are you going to do is sigmoidoscopy. Then AAPC, colonoscopy. How I remember is, since these all two are cancer, so it comes as C. So C is basically for colonoscopy, and FAP is different, so I did sigmoidoscopy. Otherwise, all those family history you are going to do is colonoscopy. So first degree relative with a cancer or adenomatous polyposis at the age of less than 60, first or two more degree, first degree relatives with the polyps or the colorectal cancer at any age, what are we going to do? Colonoscopy every 5 years, even at the age of 40 or 10 years younger than the youngest age. Then coming to the one first degree relative with the cancer or a polyposis at the age of more than 60, more degree relatives with the polyps or the colon cancer, average risk screening begins at the age 40. So this is very nicely written here. How you are going to do is, so you can remember if what kind of particular patient is coming with which kind of history, what you are going to do. So in the normal patient, like having second degree or third degree, you are going to do is average. So only those people who has first degree relative, their screening will be different. So remember that. Having second or third is totally okay. Then polyps, if the polyps come, right? This was the history of cancer. Now coming to the polyps. If the polyp is less than 1 year, you will repeat the colonoscopy every 5 years. But the polyps is more than 2, then what you are going to do is the screening will increase up to 3 years. Then cervical cancer, as I told you, age, what test you are going to do, how often you are going to do every 3 years, and what other test you can do is basically like in particular patients, if people, so some people misconcept it as more than 21 to up to date to 25. So this is not the classification of whole Canada. This is classification of Ontario. This is the classification of Canada, and you have to remember this one. Okay. Sometimes you can do start is basically 25. It says weak or moderate. So you need to see if that patient is high risk group, then you can start 25. Otherwise, it start at 30 to 69. Remember what they say in the scenario. According to that, your screening will be changed, especially in particular conditional scenarios. Okay? Then this is whole scenario, everything is same, just like the same normal you are going to do screening, inadequate you are going to do in 3 months, adequate you are going to do in 3 years. Then ascus and lsil is little different. If atypical squamous cell, I guess squamous cell, high grade squamous epithelial lesion, you are going to do colonoscopy. Now lsil, how is it different and how ascus is different? Let's do lsil. It's kind of easy. What are you going to do? You are going to, if lsil, low grade squamous intraepithelial lesion diagnosed, what are you going to do? You are going to offer patient two things: what? Colonoscopy and repeat cytology in 6 months. Whatever she choose, go with it. If that same particular patient is coming in an area where is rural area, this is very important. The setting is different now. They are not coming in the urban area, now they are coming in the rural area. So now this is basically important, how they are coming in the rural area where colposcopy is not available. So you are going to leave the patient like that? No, you are going to repeat the same test to confirm your diagnosis, because you cannot send the patient to far off, or you cannot do colposcopy. So what are you going to do is basically repeat the test in 6 months. As this is important, that you need to know this cervical cancer doesn't like spread very fast, so you can do the test in at least 6 months. So this is conditional thing. Coming in the rural area, patient doesn't want it, so this is something. But you have to offer both things if those things are available at your clinic or at the place where you are. Then if that comes as negative, at least two tests should be negative. One, repeat it again in 6 months. Then it comes negative, then you are going to do is repeat. If any time it comes as positive, anytime comes, what are you going to do is colposcopy. Then comes his ascus. You are going to see if what the female age is. I think there is a little changing in cervical cancer, but it's not upgraded in the new Toronto notes. But once it's changed, make sure you confirm that one from there and do follow that one, because I heard that in ascus it little change and now move on to the cytology in 6 months instead of checking out the age. So just confirm that one, and if I find something, I will share in the group. Then repeat cytology in 6 months if you are going to do HPV DNA testing, and then the two tests should be negative to move on to the routine screening. If anything comes up as asgus or positive, you are going to move to colposcopy. Prostate, you are not done doing in like regular basis. It's not done in Canada because its disadvantages is more than the advantages. But still, if you have to remember age, what test, PSA, how often, that is more than enough for you. Okay. So now we are screening is done. We will start from here from on tomorrow. I'm not sure if I can open up this little picture. I'm not sure. Just a second. Okay, I'm not sure. Just a second. Okay. Just a second. I'm just trying to open up a question for you guys so you can solve it, and it will help you if we can. Just a second. I think we cannot open it. Okay, if I will just read it question and you can just answer it. A 70-year-old female with a previous history of heart attack comes to your office for the first time for her routine visit. What screening test will you conduct? You can write these answer in your in the chat box, and I will tell you what the answer is. Okay, so please try writing it down. The question is, I will just write it down here too. 70-year old. This is just to check your understanding about screening. Okay, with previous history of heart attack, comes to clinic, into your clinic or office for first time, what screening test you will offer. So try writing down your answer and we will discuss it. Okay. Just write it down. It's okay. Don't hesitate to write it down. It will boost up your confidence and we will discuss from there. It will help you to even build up your concepts. Okay. So write down. I'll give you 1 minute. Everyone do participate. It's okay to get it wrong because it's screening. You just read it right now. Okay. Okay, so what did you guys write? 3 year to prevent complication. 3 year to prevent complication. What? You have to write down properly, like what kind of screening you are going to do at least for 3 years. Then Dr. Sadia write breast cancer, cervical screening, BP, and diabetes mellitus. You can write down as much as you can. How many? Like you don't have to limit yourself up to 2 or 3 or 4. Write down as many as you can. Okay. She is coming for the first time. Her age, and for the first time, you have to see what screening you can do. Okay. Then Dr. Masuma write lipid profile, FPS. Okay. Dr. Hania write mammography, cervical screening. Then Dr. Zaina mammography, pap smear, CBC, BP, body weight, EKG, troponin, vitals, BP pressure. Okay. Pap smear, weight, vaccination. Okay, breast cancer, cervical cancer mammogram, pap smear, FIT, okay, and mammogram and osteoporosis. So now this particular patient is 70 years old. Now we are going to discuss about this. She has a previous history of the breast heart attack. Okay, so first thing first, we are going to do all the screening which could be linked with the heart conditions. All of those conditions, what are those conditions is lipid profile, blood sugar levels, then all of these things, right? Then obviously along with it, she's a female and having a family history, having a heart history. So you are not going to miss the abdominal aortic aneurysm as well. So you have to rule out aneurysm as well. Okay. Then just like Dr. Ali said, bone mineral density, she is 70. Obviously after 65, you are going to do is bone mineral density as well. Then breast cancer, you're going to do, then colorectal cancer, cervical cancer, because she comes for the first time. So we are going to do that as well. So these are the basic tests you need to do because she's coming for the first time. So everything fits in it. So whoever writes it down, it's nice. Make sure to write it down in a line and it will help you how you are going to write down the question. And when you are writing it down, if you are going to write down bone density, either write bone mineral density or either write, what is called osteoporosis screening, something like, that totally like either a correct way. Okay. Like if I have to write, I will write down chat score. Yeah, you can write down chat score too for those things. But first thing first, if they give you 5 or 6 or 7 lines, then you have to write down all those basic things like breast, colorectal. If you are just writing chat score for stroke assessment and everything and just missing because of that, I told you don't miss uncommon ones just because you are saying don't miss common ones just because you are using uncommon ones. Okay. Then moving on to the next question, what would be the next question is basically 55-year-old male with a long standing history of smoking. Okay. Comes to your clinic on a routine visit. What will be your screening? He is 55-year-old, having long history of cancer, not long history of cancer, long history of smoking, comes to clinic. I'm just writing it down. Comes to clinic. What will you screen, and he is coming clinic for routine checkup. For routine. So now try writing it down for this one. 55-year-old having long history of smoking comes to clinic for routine. Now he's not coming for the first time. Remember the word. Now the word comes is routine. So now your screening would be different than the one I told you before. So now your screening, at least write down how much you can. Low density CT for the lung cancer. So Dr. Hania, why did you write COPD? uh, I mean, lung cancer is okay, but yeah, you can do COPD. But I asked about screening. So when they are asking about screening, you have to write down low dose CT scan. Writing about COPD or those diseases is not correct answer. Okay, you have to write down what at least test you are doing. Okay, not writing down COPD and lung cancer. They will take your 2 lines without giving you a preferable answer. If you write down low dose CT scan in uh, one sentence or one word, you can tell about 2 diseases, right? So it will give you a more better idea. Okay, or it will give a better idea to examiner that he's trying to rule out both of the condition in one screening. Okay. So, the Dr. Ali, the question is 55-year-old having long history of smoking come to clinic for routine. What will you do for routine visit, basically? Then Dr. Masuma write BP, weight, CBC, lung cancer. I'm not sure why you do CBC, but yeah, okay. BP, weight, and lung cancer is okay. Smoking cessation. Okay, I'm talking about screening, not counseling. Smoking cessation is counseling. Okay, make sure what I'm telling you. Just focus on those words. Mm, mm.